Welcome to the USMLE Step 2 Success Podcast. I'm Dr. Rajani Katta, author of Success on the Wards, and in this podcast, I share clinical cases with targeted teaching points. This podcast is not affiliated in any way with the National Board of Medical Examiners, and cases and teaching points are not meant to serve as an official study guide or medical guidance. I've been a faculty member for over 2 decades, and during that time, I've advised hundreds of residency applicants. I know how important standardized test scores are, but I always emphasize to my students that they're just one piece of the puzzle. It's very important to learn how to succeed and do well during your time on clinical rotations, not only because of grades, not only because of your educational experience, but also because that forms the foundation for your letters of recommendation and for the comments that go into your dean's letter. If you'd like to learn more about how to succeed in the residency match, you can sign up for a free 100-page excerpt of my book on our website, thesuccessfulmatch.com. It's a Wednesday afternoon in the family practice clinic, or it's a Saturday morning in the emergency room, or it's a Tuesday afternoon in the dermatologist's office. It doesn't matter. You could be seeing a case of cellulitis at any of these settings. And in fact, cellulitis is extremely common. It's definitely a condition where it's important to learn the clinical presentation, to learn the best initial treatment, to learn what to do if it's not responding to treatment, and to learn the important pathogens. In terms of board exams, cellulitis is also great board fodder, especially because there are a number of different pathogens that have unique clinical presentations or unique facets of history. And in addition, there are a number of important diagnoses that are important to consider in the differential diagnosis of a patient who you might suspect as having cellulitis. So in this episode, I want to run over 8 different clinical scenarios. So we're quickly going to run through 8 different scenarios that are somewhat related to a clinical presentation that you suspect might be cellulitis. Patient 1. Patient 1 is an 8-year-old young boy that you're seeing in the pediatrician's office. And his parents brought him in because over the last 24 hours, he's developed a very bright red, tender area on his cheek. As you examine him, what you note is that there's a very well demarcated area of erythema on his right cheek that is warm and elevated and tender. In this particular scenario, I could easily picture them showing you an image to look at. What do you believe is the most likely diagnosis here? Well, this clinical scenario is classic for erysipelas. Erysipelas is more superficial involvement than cellulitis. So in erysipelas, you've typically got involvement of the upper dermis and the superficial lymphatics. It is classically going to be caused by a group A strep. And so your initial treatment would typically be either cephalexin or amoxicillin. This infection would typically occur in either young children or older adults, and you might see that lymphatic involvement, but typically not going to be as serious and should respond to oral antibiotics. In the second case, this is a patient with diabetes who presents with right lower leg pain. As you examine the patient, you note that it is red, it is edematous, it is warm. But one thing you notice is that the patient is describing pain that is out of proportion to the exam. So clinically, looking at the patient, it looks to be very similar to all the other cellulitis that you've seen before, but that pain is out of proportion to the exam. As you examine the patient more closely, you do note that he has a decrease in pulses of the feet, and you note the presence of crepitus. What is the most likely diagnosis, and what is the next step? Is the next step to obtain an MRI of the right leg? Is it to obtain a CT scan of the right leg? Is it to obtain a culture of an aspirate, or is it to obtain a surgical consult? Well, in this case, the clinical features here are really almost pathognomonic for necrotizing fasciitis. Necrotizing fasciitis is an infection that goes much deeper than cellulitis. It involves not just the dermis and the subcutaneous tissues, but also the fascia, which is the layer of connective tissue that covers the muscle. This is a surgical emergency. The next step is to get an urgent surgical consult because you're developing a lot of pressure here. If this continues, you could have tissue death. Imaging may be used in some cases, but it should never delay surgical debridement. And a CAT scan would typically show subcutaneous gas, and that is highly specific for this diagnosis. Now, the next patient is also a 65-year-old patient, and he reports pain in his right lower leg. As you examine the right lower leg, you notice that it is tender, it is warm, it is red, and it is swollen. As you examine the left lower leg, you notice that it is completely normal. And as you obtain a history, what your patient tells you is that he is an accountant, but his family had gone on vacation last week. So they had driven from Texas to Florida. They had gone swimming off the coast of Destin. He specifically states that he did not have any injuries while swimming. And then they drove home, and they arrived home yesterday. As you're examining the patient, one of your first thoughts was cellulitis, but in listening to that history, you probably started to think about a different diagnosis. And with that history, the most likely diagnosis here would be deep vein thrombosis, a DVT. One thing to note about DVT is that clinically it can look very similar to cellulitis. It's going to be unilateral, typically going to be unilateral, and it will still be tender, warm, red, and swollen. This is where your history is really important. So in a patient with cellulitis, they might tell you they've just been driving back and forth to their office last week. But in a patient with DVT, you're going to look for risk factors for DVT. Or if you're considering a DVT, you're going to be looking for those risk factors. So one of the biggest ones is immobility. Were they taking a long plane ride? Were they driving from Florida to Texas? So a long car trip where they were immobile and not getting out of the car frequently. You might also have a family history of thrombosis, and certainly a patient with cancer would have a higher risk for thrombosis. With a DVT, another thing that would take you away from that diagnosis would be fevers or leukocytosis. If you had a patient with a suspected DVT, what is the next step? Would it be a CT scan? Would it be an MRI of the leg? Would it be an ultrasound with Doppler? Well, the next step would be an ultrasound with Doppler. That is used to confirm the diagnosis of DVT, and then following that, you would treat with anticoagulation. But in terms of imaging, Doppler ultrasound. Now, the next patient is somebody who tells you that they have right lower leg redness and swelling and blistering. They told you that they cut their leg from a bike injury last week, and they've been putting on triple antibiotic ointment ever since because they were really worried about getting an infection. But despite all their efforts, now their leg is red and it's swollen and it's hot and the itching is out of control. As you examine that patient, is the most likely diagnosis cellulitis? Is it deep vein thrombosis? Or is it contact dermatitis? And in this patient, they might give you that history along with a photograph. And in this patient, the most likely diagnosis would be allergic contact dermatitis. They had a bike injury, so you'd be worried about a portal of entry for bacteria. But one of the keys to the diagnosis is that the itching was out of control. Itching is not a typical feature of either cellulitis or deep vein thrombosis. Itching is, however, a hallmark of allergic contact dermatitis. Allergic contact dermatitis is the type 4 immune reaction. It's called delayed type hypersensitivity because after you're exposed to an inciting substance, it can take classically 2 to 3 days before the rash shows up, or it can take as long as 7 days. And your typical inciting agent for allergic contact dermatitis is poison ivy. But if you look at the top 10 most common allergens in North America, both neomycin and bacitracin are in the top 10. So antibiotic ointments are actually a very common trigger for allergic contact dermatitis. And actually, when I was in residency, if we would remove a mole, let's say, and we would put in stitches, we would typically tell the patient to go ahead and use neomycin or bacitracin to prevent infection. And then they had a great article that came out that showed that the rate of infection was actually similar post-operatively, whether you used a topical antibiotic ointment like bacitracin or you just used pure Vaseline petroleum jelly. And so after that, slowly the practice changed so that it would just be using something like Vaseline. And in that study where they compared bacitracin to Vaseline, what they found is that the main difference between the two groups is that there was a much higher risk of allergic contact dermatitis in the bacitracin group. And so your patient, and I've seen this time and time again, your patient who has the cut in their skin and they're using bacitracin because they want to prevent an infection instead develops an allergic contact dermatitis. And the hallmark, it could be tender, but the hallmark is that it's a lot of itching. And actually, when I'm on call for dermatology and let's say a patient calls in saying that they had skin cancer surgery 3 days ago and now they've got a red rash with blisters, should they start antibiotics? One of the first questions I ask is it itching or is it painful? And then the second question I ask is, what have you been putting on it? So for that patient, allergic contact dermatitis. Now the next patient is somebody who, let's say your mom calls you and your mom tells you, honey, I was cutting up fish 2 days ago and the knife slipped and I got this cut in my finger. Well, now it's 2 days later and my finger is completely red and swollen. Do you think I need antibiotics? What do you think this is? And then you ask her, well, Mom, are you having any other symptoms? And she tells you, no, I don't have any fever. I'm doing okay. It's just that my finger is really bright red and it's right around the area where I cut myself. What would be the most likely causative agent? Is it Staph aureus? Is it Strep pyogenes? Is it erysipelotheryx? Or is it Pseudomonas aeruginosa? Well, in this case, it would be erysipelotheryx. Erysipelotheryx is a gram-positive bacillus, and it causes what's known as erysipeloid. So even though erysipeloid is not the same thing as erysipelas, I think the reason they call it erysipeloid is because it can look very similar. So it can give you that red, pretty well demarcated sometimes elevated area. But one of the key features is that it occurs after a portal of entry, typically with exposure to an animal or a fish. So the other name for erysipeloid is fish cleaner's disease or bull's finger, or they might call it butcher's disease. But erysipelotheryx is a gram-positive bacillus, and it's widespread in both nature and in domestic and in marine animals. So that's why you get this, classic history of maybe an occupational exposure like a fisherman or a butcher or somebody who's exposed to those animals and then has a portal of entry, let's say from a cut, from a knife injury or a cut, and then that erysipelotheryx gets deeper into the skin. And typically what it causes is this subacute cellulitis of the hands or fingers. And systemic infection is pretty uncommon. It's going to be a skin infection. And your treatment, since it's a gram-positive bacillus, is typically going to be penicillin or amoxicillin. Now, the next case I'm going to ask is a dog or cat bite. And here the question would be, what would you think would be the most likely organism from a dog or cat bite? And so here you're thinking about a different range of bacterial pathogens. And the three to really memorize here would be first, Pasteurella multocida. The second would be Capnocytophaga species. And then the third would be Bartonella henselae. And yes, you might think of that last one as cat scratch disease, but it could also be from a cat bite. So again, the three to memorize for a dog or a cat bite would be Pasteurella multocida or Capnocytophaga species or Bartonella henselae. The next clinical scenario that I want to give you is a patient who comes in and they tell you that both of their legs are really red and swollen. And when you get a deeper history, you find out that they've been red and swollen for weeks. And as you examine it, you notice that they have bilateral edema of the lower legs. They also have a lot of erythema with scaling. And there's also a background of hyperpigmentation and hypopigmentation. This is a classic clinical appearance of chronic venous stasis dermatitis. So venous stasis dermatitis occurs in a setting of chronic venous stasis. So this would be a patient who has a reason to have chronic venous stasis. And then on top of that, they've developed inflammation of the skin. That's why they call it stasis dermatitis. And that inflammation of the skin is typically going to be red, scaling, may have hyper or hypopigmentation. Now, the one thing to be aware of in chronic venous stasis dermatitis is that because you have that inflammation of the skin, it can serve as a portal of entry for bacteria. So you could develop a cellulitis in that setting. So that's one thing to remember. The final scenario I want to give you is one that I think the boards just love the scenario, but it's one that can be really concerning and worrisome. So you're working in the emergency room in Houston, and a patient comes in. He went out on his boat in Galveston last weekend, and he scraped his leg when he was getting back in the boat. And now he comes in 2 days later because his leg is red and swollen and incredibly painful. And as you examine his leg, you notice that in addition to the redness and the edema and the pain, he's also got multiple hemorrhagic bullae. What is the most likely causative organism here? Well, this is a really classic scenario for infection with Vibrio vulnificus, which is a gram-negative bacteria. One of the classic clinical features is that it's a cellulitis with hemorrhagic bulla. That doesn't need to be present, but it's very classic, and so I could see them showing you an image of that. And then the history to really be aware of is that the patient had an injury with water exposure. And there was a really sad case of a patient who had a recently healed tattoo just a week before and then was exposed to salt water and likely exposed to Vibrio, who then developed a Vibrio infection because the tattoo wasn't completely healed over, and so it served as a portal of entry. And when you think about Vibrio vulnificus, that gram-negative bacteria, it is present in water. And I thought there was a really interesting statistic that I saw, which is that Vibrio can be found in almost all oysters in the Chesapeake Bay area or in the Gulf Coast once you get to temperatures above 68 degrees Fahrenheit. And so Vibrio doesn't just cause skin injuries, it can also cause systemic infection, especially if you've consumed raw oysters that are infected with Vibrio. But in this case, hemorrhagic bulla in the setting of somebody who had a cut serving as a portal of entry and then was exposed to water. The other water injury organism to be aware of would be the Eromonas. So when you think about your patient where they're leading you to think about a diagnosis of cellulitis, maybe a red, warm, painful, edematous leg, these are some of the other unique clinical scenarios that you need to think of. And you're looking for clues in the history and the physical exam. So you definitely need to think about erysipelas, your young children, your older adults. Because it's more superficial involvement, it'll be bright red, elevated, well demarcated, still a group A strep. Or you might have to think about your necrotizing fasciitis, especially if you've got pain out of proportion to the exam, definitely if you have crepitus. And remember that this is a surgical emergency, so you go straight to a surgical consult because surgical debridement, urgent surgical debridement is necessary. With your deep vein thrombosis, remember that your clinical features are going to be almost exactly the same. Unilateral, tender, warm, red, swollen. So here's where your history is going to be really important. Do they have a history of immobility, or do they have a family history or a history of cancer? With contact dermatitis, remember that it could also be in the setting of a cut in the skin, and it could also be red and swollen. They might even have blisters. But itching is going to be an important feature, and you're also going to look for them having used something that might have triggered the contact dermatitis, such as a neomycin or a bacitracin. Now, the next scenario would be somebody who is, let's say, cutting fish or butchering meat, and then developed a subacute cellulitis of the hands or fingers. And here you're thinking about erysipeloid, which would be due to erysipelotheryx, a gram-positive bacillus. And even though this is rarely systemic, you're going to treat, because it's a gram-positive bacillus, typically with penicillin or amoxicillin. If you have a dog or cat bite, remember those top 3 organisms: Pasteurella multicida, Capnocytophaga species, or Bartonella henselae. If they show you a picture of somebody with bilateral redness and swelling, also with scaling, and maybe with hyper or hypopigmentation, don't think infection. Now you're thinking about chronic venous stasis dermatitis with skin inflammation that's due to the underlying chronic venous stasis. And finally, if you had somebody who is out on their boat and they cut themselves, or maybe they had an oyster shell cut, and now they have a cellulitis that has hemorrhagic bulli, and a lot of these patients are going to be systemically ill, you need to think about Vibrio vulnificus, which is a gram-negative bacteria. Water injury might also make you think of Eromonas. So that was your quick run through to differential diagnosis of uncomplicated cellulitis, some scenarios that the board loves, and for some of these, be ready to recognize those images. So it would be important for you to look at an atlas to make sure you know what these look like clinically.